Morning, everyone. Thank you for coming to this session this morning. The talk I've been asked to give is on NASH and NAFLD as a cause for HCC, because this is a meeting where a lot of us are clinical people, and it's really talking about clinical practice. I'll try and make this as relevant to clinical practice as possible. So this is the problem that we're all facing. We've got, this is actually showing you International Agency for Cancer Research data, looking at a time period of about 30 years. And what we're looking at here is in different parts of Europe, Southern Europe, and here we've got Northern Europe, looking at the prevalence of HCC or the incidence of HCC. And in those countries where hepatitis C is highly prevalent in Southern Europe, there's always been much more HCC in those countries, whereas if you look in Northern Europe, not so much hepatitis C and a much lower prevalence. But what's happened is that as we've developed treatments for viral hepatitis, there hasn't been the fall that we've hoped in these countries with a higher prevalence. This has stabilized, and in those countries that have had a lower prevalence, we've seen this storming increase in the numbers of cases of liver cancer. And these are the common causes, viral hepatitis, but this isn't a mystery anymore. We know that this is associated really with the prevalence of obesity and NAFLD and NASH and all the things that we heard yesterday. This is data from Cancer Research UK looking at mortality attributed to hepatocellular cancer, and over a period of looking at 2 years in 2003 to 2005, and then looking 10 years later, looking at the causes of cancer mortality. And you can see that for all of those common cancers where there are good treatments, early detection programs, the mortality is falling, and that's not the case for liver cancer here, where in both men and women, in that 10-year gap, there's been a huge increase in mortality, and that is a cause of cancer death. And this is the further depressing data, and this is the predicted rise in hepatocellular cancer cases that we're likely to see in the UK up until 2035. There's this predicted increase in incidence of hepatocellular cancer that we're likely to see. And so this is a big problem. We do understand, we think, why this is happening. It's related to obesity and NAFLD, but what can we actually do about it? We need to know if we can prevent it, can we detect it earlier so that we can intervene with curative therapies, and if the patients get the liver cancer, can we actually treat it in this group of patients? So we need to understand more about the pathogenesis of liver cancer in patients with NAFLD and obesity so that we can identify the patients with NAFLD that are going to get it, and also we need to understand if it's the same as other cancers. Can we just use the treatments that we use for viral hepatitis related HCC in patients with NAFLD HCC? So the first thing that we just need to understand as a cause for liver cancer is about cirrhosis. So cirrhosis is the greatest risk factor that there is out there for patients with liver cancer. And here we're looking at the histology of a normal liver. And to remind everybody, this is the portal tract where everything that's coming into the liver comes in. You've got an artery, hepatic artery, with that oxygenated blood. You're also going to have in there a branch of the portal vein, bringing in the nutrients from the bowel. And you've got the bile ducts, and everything that comes in traverses these sinusoid sheets of liver cells on its way out in the central vein. And if you think about this in a three-dimensional way, this is an intricate network of what's coming in and what's going out, with single cell sheets delivering everything that needs to go into the hepatocytes very efficiently. And then when you have an injury here, you get a healing response, inflammatory cells, scar tissue, and this nice a three-dimensional network of plumbing is totally disrupted. You get scar tissue between the portal tracts, between central veins, and so you end up with this over here. Lots of nodules of regenerating hepatocytes. There's injury, they're trying to regenerate, they're growing fast, they're still being damaged, but there's this cirrhotic appearance of that scarred liver with no effective delivery or outflow anymore, and that's why these patients get portal hypertension. But it's within these nodules with ongoing damage and a proliferative drive where the cancers develop. And here's a patient that would have cirrhosis caused by NAFLD. Here we've got fat in the hepatocytes, and in this case you can see ballooned damaged hepatocytes. But the problem that we face is that a lot of NAFLD patients, the majority, have this. This is simple steatosis, so fat in hepatocytes without inflammation and scar tissue, but then they can also have this, where you have no scar tissue, obviously, but ballooned hepatocytes, inflammation. And these patients in NAFLD or the metabolic syndrome are also at risk of getting liver cancer, even though they don't have cirrhosis. So if you have a patient that gets a cancer, is the cancer different? The commonest way to actually assess this is by looking at the histology. And because we don't biopsy patients very often to make the diagnosis of liver cancer, we use radiology because of the risks of biopsy. We don't actually know the answer to this. We don't know if they're different in patients with NAFLD. All of these histological subtypes occur, and we do know that there are two new kids on the block, if you like, steatohepatitic cancers, cancers that have a lot of inflammation and fat in them, and then this combined hepatocholangiocarcinoma histological subtype, and they perhaps are more prevalent in patients with NAFLD, but we're not really sure. These days, if you ask if a cancer is different, you also ask about the genetics or the epigenetics, because everybody's obsessed with big data sets of looking at gene expression and DNA changes. Are these different? And we don't know the answer to this either. Those NAFLD patients with their cancers, they're not well represented in the big studies that have been done so far. There is data from the Cancer Genome Atlas where tissues from hundreds of patients have actually been sequenced and looked at their messenger RNA expression. But actually in those hundreds of cases, there's about 20 patients with NAFLD, so we can't really use that very much. There is a study here from Japan where in a large series of patients undergoing resection, over 200 patients, there were 10 that had NAFLD HCC. And so this was published a few years ago. They'd done whole exome sequencing on the cancers in those cases and compared them to the other cases. And actually, the mutations that were seen were the mutations that you see in viral hepatitis-related cancers, TERT, beta-catenin, P53, and there were similar changes in the losses and gains of chromosomes. They identified this one that might have been significantly different, but actually the numbers were very small. So probably the cancers themselves are similar. So what we're left with is looking at the environment in which the cancers develop and trying to understand what's different about that. And this is from a recent review that we co-authored with Matthias Heichenwalder. And here we've got the stage that we see: simple steatosis in the liver, inflammation, the NASH that patients get with fibrosis, and then advancing all the way through to getting the cancers. And we know that this process is more likely to occur in men, older people. The older and longer you have this, the more likely you will get progression to cancer. We know that type 2 diabetes is also one of those things that will drive the development of cancer. Drugs I've put in there because if we're seeing these patients, there are some drugs that protect patients from getting liver cancer. So if you're in general practice, put your patients on metformin if they're diabetic, or on statins because they can be protective. But we think this is all really about oxidative stress, damage going on in this environment, and in response to that you get this inflammation. And it's not just the inflammatory response with the scar tissue that you're getting there. You've got the immune surveillance cells, the T cells, the killer cells that go in there and pick out damaged cells. Perhaps they don't work effectively anymore. And so that mutation from the DNA damage actually can turn into a cancer because it's not being effectively removed. And then we have this healing or proliferative response in the hepatocytes to that ongoing damage, which is where that cancer starts to develop. Now, I wanted to put this in because it's data from Newcastle. A lot of that data has come from animal models where we're looking at damage and fat and regeneration. But this is 10 years ago. Vlad here got funding from the European Union. I was part of that. This is the FLIP project. And from that money, we created an animal model of fatty liver disease. We chose a mouse background that is likely to develop diabetes, and we gave them the American lifestyle diet so that the mice got obese and they developed impaired glucose tolerance. And the mice got a fatty liver, they got large cancers. Even if you didn't give them an additional insult, if you gave them a mutagen, you exacerbated this. And 95% of the mice got cancers. And here you can see the abnormal nuclei in the cancers that these mice got. And so we'd actually done more in this study other than developing the model that reflected human disease, we went on to treat them with an antioxidant called butylamine because we wanted to see if there was an effective treatment that would reduce NASH and inflammation and fibrosis and reduce the incidence of liver cancers. And so this is what we found. If we focus here on this panel, this is ballooning degeneration, showing you the damage to hepatocytes. The butylamine wiped that out. The NASH score that we used to look at the severity of NASH was very significantly reduced. And here we look at DNA damage. This is measuring what are called H2IX foci in the nuclei of hepatocytes. And in the presence of that antioxidant, we wiped it out. And this is quantification. Whether or not you had that diet that induced the damage, or the control diet, really you obliterated the amount of DNA damage. But the problem was that even though we did that and the mice got less fibrosis, they got just as much cancer. And what we didn't impact with that antioxidant was a regenerative response. This is Ki-67. So here we've got lots of proliferating hepatocytes in the livers of those mice, regardless of the fact that they haven't got DNA damage anymore. So what this is telling us that there's an inflammatory response to fat that drives proliferation that is independent of DNA damage. And what we actually showed was that part of that inflammatory response was this here. This is a lipogranuloma, fat in the liver, not in the hepatocyte. It's come out of the damaged hepatocyte, and the macrophages have moved in to clear it away. If the mice had lipogranulomas, they got cancers. And if they didn't have lipogranulomas, they didn't get cancers. So this is telling us that's really important. It's not all about DNA damage. It's fat and the type of immune response you get. So if we come back to this, our figure of NAFLD pathogenesis, this is all very nice, but actually mice and men are not the same. We in this study, we took male mice, we aged them, they got fatter, they got diabetes, and they all got liver cancer. In the real world, if humans, this doesn't occur. You get fibrosis and cirrhosis and cancer in about 20% of NAFLD patients. If you don't get cirrhosis, the percentage of patients getting cancer is less than 1%, and it's probably all about the genetic predisposition. The genes we heard a little bit about yesterday, PNPLA3, TM6, SF2, they regulate fat. It's about the type of fat different people get in their livers. And what we think now, and we're working on this in Newcastle, is that it's about immunoregulatory genes. It's the combination of what happens to the fat in your liver and the immune response to it that probably determines your risk of getting cancer. But what about treatment? Vlad, how much time is there left?
Take your time.
What about the treatment? So this is coming back to the questions, are the NAFLD HCC patients the same as other HCC patients, and should we treat them the same? And the answer is they're not the same. This is data from Newcastle, from when I started and set up the liver cancer practice. The colors of the bar here is telling you the underlying etiology of the cancer in that patient. The orange bar didn't even exist in the year 2000. This is 2016, and it's NAFLD. It's NAFLD HCC. So the majority of patients in our unit have either got NAFLD as the cause of their cancer, or the green bar is alcoholic liver disease. And when you actually look in the whole cohort, which is actually nearly 1,000 patients, and you look at the phenotype of this consecutive cohort of the patients with NAFLD, I can tell you that they're older than the viral hepatitis patients, and it's obvious, but they have the metabolic syndrome. And when you're thinking about treatment, you can't ignore that. And then we've got these patients that get cancer without cirrhosis and fibrosis. And those patients, they're older still. So yes, you want to try and treat them, but just be careful that you don't do them more harm. Because when these patients come to the clinic, they rarely come looking like this. They more often come to your clinic looking like this. And these are not the patients that were used in the evidence base that has created the management algorithms for patients with liver cancer. And so for those of you that aren't familiar with it, I'll summarize this very briefly. It's the Barcelona Clinic for Liver Cancer Management Algorithm. And so what you're hoping is that here you've got a cirrhotic liver with an HCC in it. This is the prognostic stage, the treatments, and how long you're hoping your patients are going to survive. So we hope to find patients over on that side with early cancers where you're going to think about ablative therapies and cure. For our NAFLD patients, We don't find them at that stage. We find them at this stage where they've got advanced disease, they're getting supportive care, we can't give them cures. And so we're thinking about palliative treatments. We do have to remember that actually there's all those patients that don't have cirrhosis. They're not included in this algorithm. So potentially, even if they're older, if they haven't got cirrhosis, they've got a larger cancer, maybe you could ablate them, maybe they could have a resection, but you have to have a way of actually assessing their fitness for that. And you have to remember that they're older with comorbidities. This is when you're thinking about local regional therapies, ablation or medical therapies. In the algorithm, there's no real guide telling you what to do. If your patient's got cardiovascular disease, renal impairment, they're in a wheelchair because they've got diabetic feet, you really have to try and come up with your own way to manage these patients because they're not the same. So just to summarize then, for those advanced patients, what about medical therapy for liver cancer? Sorafenib, there was a landmark trial published in 2010. This is a multi-kinase inhibitor, and it was the first medical therapy ever to show benefit in patients with liver cancer, which is great news, but the benefit in survival was 10 weeks, a median of 10 weeks. Some patients doing really badly, some patients doing better. So potentially, you might be able to get an extra year of life, but the median is 10 weeks. And so when this was released, everybody was wanting to use it. Years down the line, Judy Bruges and the Asia Pacific leads put their data together, and they looked at, this is over 800 patients that have been treated with sorafenib in those trials, and they did the sub-analyses to work out which were the patients that did better and which were the ones that didn't. And so this is a bit disappointing, really. If you just look, first of all, we see the patient, they've got extrahepatic disease. So we tell them in the clinic, well, you've got extrahepatic disease, we'll give you the medical therapy that actually treats all of your cancer. But actually, they're not that likely to respond. This is still significantly different if they have extrahepatic disease. They're much more likely to get benefit if they don't. So don't wait too long to treat your patients. It's still worth trying, but if your disease is advanced, that's the most important prognostic factor and predictor of survival. And the same goes for tumor burden. If you have a huge cancer, your likely benefit is not going to be that great. But this is the really disappointing thing, and data that I wish they'd shared at the beginning, because this is the difference compared to whether or not you have hepatitis C and whether you don't. So all of our NAFLD patients, they're actually in this group here. So for the patient who's young with hepatitis C, who's fit, that median survival of 10 weeks is probably a year, whereas in our patients with NAFLD, it's probably, a median survival of 1 to 2 weeks, with a lot of patients not getting any benefit at all. So really, should we use this in our patients at all? And what we've done in the UK, our oncologists have put together a big audit of all the patients that after we license sorafenib, this is real-time data, what happens to the patients where we actually use it. And it's not as bad as you might think. Actually, when they looked at our patients, their age was 68, so that's older. There were quite a lot of NAFLD and ALD patients in there, and they did get benefit. You can't compare this, it wasn't randomized, but their median survival, if you selected the right patients, was in the order of a year post-treatment. But what they did identify was that if you had mildly impaired liver function or an impaired performance status, there was no benefit. And so that's changed our practice. We don't even think about using sorafenib in an older patient whose performance status is impaired or they've got slightly abnormal liver function. Is there anything else? So we do have lenvatinib now, another multi-kinase inhibitor, and this is the trial that showed it's not inferior to sorafenib, so you could use it. No data yet in patients with NAFLD. There's a different side effect profile for this drug, so it might be better tolerated. So it's something to consider. Second-line therapies, these drugs, I don't know how many people have got access to them or use them, but again, this is regorafenib. It's sorafenib with a slightly different post-translational modification, that fluoride up there on the drug, and there is some benefit in some of these patients in the studies. They're all younger patients. Very few patients actually had NAFLD, so we don't really know yet whether it's of any benefit. And the same goes for ramucirumab. This is a VEGF receptor antagonist. These are the trials which actually looked at enrichment in patients with alpha-fetoprotein expressing. Yes, there was a benefit in these patients, but again, they were younger. Not many of them had NAFLD. And the same goes for cabozantinib, which is a MET inhibitor. Younger patients, and not many of them had NAFLD. The sort of changer that might be exciting for our patients are the checkpoint inhibitors. So these are T cells, inhibitory receptors on T cells, our natural immune response aiming to keep our immune defenses in check so that we don't damage our body, and the cancers exploit this and they use this and switch off that T cell response. If you inhibit that, you can actually get some responses to slowing down the growth of cancers. These are the studies that have looked at now over 2,000 patients with HCC, and perhaps there are now, regardless of etiology, patients that will respond. The disappointing thing really is that regardless of etiology, extrahepatic disease, it's only 15%, and we don't really know why. I'm not going to go through this. If people want to look at it, this is how we manage patients in Newcastle. It's the Barcelona algorithm is here, but it's what we do with our patients, and that's the reference if people have their own patients to look at. So just to summarize what I've told you, we're starting to understand the pathogenesis, the cause of liver cancer and NAFLD. We know that this is going to be important for surveillance strategies and therapeutic development. This is that timeline we saw before, so we might be able to develop the tools that will help us identify groups for surveillance for liver cancer, understanding more about the genotypes, and these might be the things that we would target for therapies in patients with NAFLD HCC. A lot of these, though, they're immune-related targets, so that's what's going to be key. When you're looking at your patient now and what we've got available, just remember they have the metabolic syndrome, they're older, they have comorbidities, so be careful with what you do to them. Acknowledgements for me and thanks. This is really the liver cancer group in Newcastle, Vlad and the FLIP team, which was the first big grant I was ever involved with. More recently, we've now actually had success with a funded collaboration by the charities in the UK, Italy, and Spain. And this is the Hunter team working together to define the HCC immune environment to try and develop better therapies for patients with liver cancer. And for me, that's NAFLD-related liver cancer. And this is our website if people are interested in finding out what's going on. Thank you.